All right. It's my great pleasure to introduce Dr. Lan Han, who's a head and neck and molecular pathologist at Mount Sinai Hospital. Of course, I know Ilan from our pathology residency days. Um, I think you were in Hamilton before that, eh?
Yeah, med school at McMaster.
Yeah, master, and then we overlapped during residency at U of T, and then he was at the TGH for his head and neck fellowship. Now he's at just across the street. He's got some interesting cases for us to discuss. Take it away, sir.
All right, thank you. Yeah, so I'm going to be speaking about the role of molecular diagnostics in incongruent clinical pathologic cases. I'm going to discuss 3 cases today. So first, we'll go over the learning objectives, then we'll get right into the cases and have a little bit of an open discussion at the end. So hopefully, after the session, we'll be able to appraise competing evidence in incongruent clinical cases, use molecular testing results to answer some unconventional questions, and try to integrate those results into a surgical pathology report. So we could get right into it. Case number 1 is a 75-year-old woman. In 2015, she had a parathyroid lesion removed, and that was diagnosed as parathyroid neoplasm suspicious for carcinoma. At the time, she had an elevated PTH. Since then, she's undergone routine ultrasound screening for recurrences, and it's been negative until recently. There was enlargement of a lateral neck lymph node, and screening CT showed that there were lung nodules as well. Her PTH was not elevated. So the clinical impression is that of recurrent parathyroid carcinoma or a lung primary. So this is the neck biopsy we got first. As you can see, it's pretty scanty. This was probably the best core, and this is the one we did immunohistochemistry on and exhausted. You can see the specimens demonstrating carcinoma involving fibrous tissue. There's no lymph node tissue identified. The cells are large and pleomorphic. They're eosinophilic. There is mitotic activity, not in this field that's easy to see, with atypical forms, scattered apoptotic cells, no tumor necrosis. On immunohistochemistry, typically we're expecting parathyroid carcinoma to be positive for keratins and neuroendocrine markers, as well as GATA3 and PTH. So this tumor was positive for keratin, but it was very focal. It was positive for GATA3 and neuroendocrine markers, synaptophysin and chromogranin. It had retained parafibromin, which can be lost in parathyroid carcinoma. It is negative for a bunch of thyroid markers, other keratins, PGP9.5, which is a marker of parathyroid carcinoma, which is usually positive in carcinoma, and it's negative for PTH. The P53 is lost, which is an abnormal mutated pattern, and there's reduced RB staining. The proliferative index is around 70%. So having all of this information, I went back to pull the case from 2015. So as you can see, this is a large parathyroid lesion. It's encapsulated. It shows chief cells, oxalophilic, and clear cells. So it's a mix of oncocytic, eosinophilic cells, and clear cells. There is a atypia that's present and pretty apparent from this power even. You can see some of the enlarged nuclei. With parathyroid, we see that sometimes, like endocrine type atypia. So that alone is not a diagnostic of carcinoma. Fibrous bands are an atypical finding, but again, not alone diagnostic of parathyroid carcinoma, but they're atypical to find in a parathyroid adenoma. And if we look at the bottom of the screen, that's the area that was suspicious for vascular invasion. And parathyroid tumors are unique in that we only call them carcinoma when there's unequivocal evidence of malignancy, that being invasion into other structures, lymph node metastases, or vascular invasion. So while if this was convincingly in a vessel and in more than one vessel, this would be called parathyroid carcinoma. At the time, we were not convinced that it was definitively within vessels as an invasive process. So that's why it just got called suspicious for carcinoma. Here, there's more atypia we could see in large bizarre cells, multinucleated cells, macronucleoli, mitoses, including atypical forms. And again, this is a higher power of the area that was suspicious for vascular invasion. So this tumor by immunohistochemistry was also positive for keratins, more than the neck biopsy, but still more focal. Neuroendocrine markers were positive. It was positive for PTH and GATA3, so that's a difference, the parathyroid hormone staining. And P53 was not overexpressed. There was focal loss, which was interpreted at the time as a fixation artifact, dropout in staining. And the proliferation index is 15%. So we're comparing these two lesions, and it's an important clinical decision point as to whether this patient is treated as a lung primary or as a recurrent dedifferentiated parathyroid carcinoma. I say dedifferentiated because it's losing parathyroid hormone staining. So we compare the morphology. Look a little different. They do have similar areas. So, with the eye of faith, you could convince yourself that if the oncocytic component is the one that recurred, that's what we're seeing, but not fully alike. The immunohistochemistry is quite similar because GATA3, neuroendocrine markers, keratins are focal, so those are quite similar. But parathyroid hormone loss, which was expected clinically because there was no elevation in parathyroid hormone, and P53 staining being different. So those two differences are a little soft because we already may be expecting it to be dedifferentiated, although that's a very rare occurrence. And the P53 is a little soft because it is abnormal, but we did have loss. So are we going back and reinterpreting those areas of loss as mutation or as fixation artifact? So the differential diagnosis remains the same: recurrent dedifferentiated parathyroid carcinoma or large cell neuroendocrine carcinoma of the lung. So how do we answer this question? We go to molecular testing. So the current neck biopsy had a tumor cellularity of around 30% and showed a VUS in ATM and a pathogenic TP53 variant. The prior parathyroid tumor we tested from 2015 had a cellularity of 90%, the same VUS and ATM, and TP53, the same variant. So this ATM VUS is absent in cosmic, absent in the general population, to sort of rule out a SNP, and it's very highly conserved as per the UCSC genome browser. And the TP53 variant, the specific mutation had around 100 samples with that specific base mutation. The amino acid mutation had a little more. Varying types of tumors were reported in cosmic database. In general, TP53 mutations are the most common event in large cell neuroendocrine carcinomas of the lung, affecting around 92% of tumors. RB is next at 42%, and they're co-mutated in approximately 40%. The current practice is to sort of accept abnormal RB and P53 together as evidence, not definitive evidence, but evidence in the column of neuroendocrine carcinoma of the lung. And TP53 and parathyroid carcinomas, obviously much less common and less studied, but are present in around 40% of parathyroid carcinoma cases. And that brings us to our first polling question. What is the source of the neck mass? Is it a lung tumor? Is it the prior parathyroid lesion? Or is it something else? Okay. Well, I have to say I agree with you guys. So that was my conclusion. And we could go on to the next case and sort of discuss them all at the end. So case number 2. So this is a 70-year-old male. In 2022, he had a moderately differentiated squamous cell carcinoma removed from his tongue with negative margins. There was no lymphovascular invasion identified. There was perineural invasion. There was after radiation finished, after his course of radiation, he noticed an enlarged neck lymph node, which was biopsied as squamous cell carcinoma. A couple months later, or a month later, he had a neck dissection, and it was just that one node that was positive. Then 3 months after that, he had a neck skin nodule in the same area on the neck, in a sun-exposed area, a skin nodule. And clinically, the question was, is this a primary skin tumor, squamous cell carcinoma, versus something reactive? Because it seemed like it was subcutaneous or dermal, but there was a breakthrough to the skin. Or is it a metastasis of the squamous cell carcinoma? And this is what the skin nodule looked like. As you can see, it has a very broad connection to the surface. And it grows in like a cup shape, sort of downwards. And this is indicative of a primary cutaneous process or a primary process. And that central keratin plug is also of a specific pattern, almost keratoacanthoma-like, is probably what this would be called in the skin, keratoacanthoma-like well-differentiated squamous cell carcinoma, because it's not just pushing, there is invasion. Flanking, there are areas that look like dysplastic changes basally on one side and on the other side. And then in the dermis, there is some elastotic degeneration, evidence of sun damage. So this really looks like, aside from the clinical picture, this looks like a primary cutaneous malignancy. The one thing that's a little strange, where there were these two plugs of tumor in vessels, one of them more muscular, more of a muscular wall, deep to the tumor. So the impression, I tried to differentiate these tumors to see if there's any immunohistochemistry that could differentiate between the tongue and the skin and those vascular deposits, because those were really bothering me. So I did PD-L1. That was the only thing that actually showed some difference in staining. So the tongue had a CPS score of greater than 20. Those vascular deposits also were very positive, but the skin tumor was negative. Cyclin D1, CK7, P16, GATA3, RB, P53, all of these things that can be mutated in oral cancer and squamous cell carcinomas, they're sort of variably expressed, but I was just hoping to find a difference between one of these components, but those all showed the same staining. So at the end, and showing it to a lot of colleagues as well, we favored this to be a cutaneous primary tumor. But a week later, a new skin nodule adjacent to the prior excision came up, and it was biopsied as squamous cell carcinoma. So that clinical picture of immediately a rapid recurrence for a skin tumor like that is very atypical. And that definitely pushed the clinical impression towards that of MET from the tongue. So at this point, maybe you guys know where this is going, but we did molecular testing. The skin nodule number 1, that one that I showed you, 80% tumor cellularity, had a TERT promoter mutation and a TP53 mutation. The second skin nodule looks the same. And the prior glossectomy from 2022 also shares the same mutations. So this specific TERT mutation is present in 15% of cutaneous SCCs. Oral squames have TERT mutations in around 80%. And then if we're going to look at that specific mutation, which is the second most common, but still much less common, TERT promoter mutation, the 146, it's present in around 30% of all of the head and neck cancer studied. So that wasn't just limited to oral, so it's probably closer to 20%. And in addition, TERT promoter mutation status has been used to prove a common origin or clonal relationship in urothelial carcinoma, like in this Brown paper. This is an example of one patient with urothelial carcinoma. They microdissected different components, including conventional invasive high-grade urothelial carcinoma, at top left, squamous differentiation within the carcinoma in the middle, carcinoma in situ at the bladder dome, top right, carcinoma in situ, left lateral bladder wall, prostatic urethra along the bottom, and in the bottom right, metastatic to lymph node, and all of these had the same TERT promoter mutation. The authors concluded that they had the same origin and that they were related. And it was the more common TERT promoter mutation of the 124. Looking at that TP53 mutation, very well described. TP53 has a lot of well-described mutations, though. And then looking at TP53, the specific mutation in cosmic, it's present in across a wide variety of sites. A lot of these skin tumors were melanomas, but there were some squamous, obviously, and upper aortodigestive tract is there as well. And that brings us to our second poll question. What is the source of the skin lesions? Is it a new primary? Is it the prior tongue squame? Or is there another source? All right. Okay, so we're all in agreement. And that brings us to case number 3. So this is a 75-year-old man presenting with a large neck mass, 15 centimeters, huge mass, immediately under the skin. Biopsy of the neck showed a poorly differentiated carcinoma. There was PAX8 staining, so the pathologist raised the possibility of thyroid and kidney primary. During an ENT surgical consultation at my institution, there was a right hypopharyngeal lesion noted, and the clinical impression was that of metastasis, but noted was the large size of the neck mass and the relatively small size or asymptomatic nature of the primary tumor. So in this neck biopsy, it was a basaloid tumor infiltrating fibrous tissue. The cells were pleomorphic, large nuclei with irregular contours and prominent nucleoli, brisk mitotic activity, including atypical forms, frequent apoptotic cells. There was no overt squamous differentiation. There was no overt line of differentiation, period. It was positive for keratin, although it was weak and patchy, so something very poorly differentiated. P63 was weak, which points a little bit more towards squamous differentiation. GATA3 was positive, BERT-EP4 and vimentin were positive, cyclin D1 was overexpressed. It was negative for other keratins, including more specific high molecular weight keratin CK5 for squamous differentiation, same with P40 for squamous differentiation, and negative for pretty much everything else we threw at it, and we exhausted the tissue, so we had to conclude poorly differentiated carcinoma, favor metastatic carcinoma just because of its location in the neck and some other enlarged lymph nodes. But, in the back of your mind is the possibility that it's a primary, maybe a skin and nexal primary, given the BERT-EP4 positivity and basaloid look of it. And this is what the hypopharyngeal lesion looked like. You can see that bottom sample has squamous cell carcinoma. At the top end, there is carcinoma in situ. And then throughout the rest of the tumor, it's very keratinizing. It's moderately differentiated. Nothing looks poorly differentiated here. Again, keratin pearls throughout, and it's nicely sampled, and it looks all moderately differentiated and keratinizing. By immunohistochemistry, it's P16 negative. Cyclin D1 is overexpressed, and it's PD-L1 positive. So the impression that we have here is a moderately differentiated squam in the hypopharynx, probably the source of the neck mass. But again, we don't have evidence of a poorly differentiated or non-keratinizing component in the primary tumor. So this patient went on to have a neck dissection. 5 out of 30 nodes were positive for poorly differentiated carcinoma. All of the involved nodes were small, and they were very clearly nodes because they had lymph node structure and parenchyma, except for the dominant mass, which totally must have obliterated the lymph node structure, and it pushed up against the skin with ulceration. This is what it looked like. The necrosis, as you can see, especially in the bottom right corner, gives a papillary or pseudopapillary appearance. If we go closer, there's a lot of necrosis, as you can see. And the cells are really poorly differentiated. They're polygonal, some pale to amphiphilic cytoplasm, marked pleomorphism, prominent nucleoli, lots of apoptosis as well, and mitotic activity. The overlying epidermis was ulcerated, but there was no dysplasia, and there's no evidence of squamous differentiation anywhere in this 15-centimeter tumor that I sampled. This area at the top, that was at the top left of the screen, is more poorly differentiated even because that patchy P63 is lost in this component, and as you can see, these are more primitive looking cells, more open, more pleomorphic. By immunohistochemistry, this was P63 weak to lost. The keratin was very patchy and focal. And again, all of these stains weren't very helpful. There was no specific line of differentiation here at all. But given some p63 staining, some keratins, we think this is a poorly differentiated carcinoma. And the dominant mass here measured 14 centimeters. It was infiltrative. There was no lymph node tissue identified with the mass, but given its location in the neck, that we have a primary source that's ipsilateral, accompanying positive nodes, we favor that it represents a metastatic lymph node or multiple matted lymph nodes. And, it's poorly differentiated basaloid carcinoma based on the p63, most likely squame. So right now it's probably metastatic, it's probably squame, and given that, it's probably from this hypopharynx primary. It was all moderately differentiated squame in the biopsy that we saw, but it was just a biopsy. So it might not be representative of the entire lesion, which may include a poorly differentiated component. So to answer this question, let's go to molecular testing. So our neck mass showed tumor cellularity 80%, and the specific, more rare TP53 variant than we'd seen before, and the hypopharynx showed the same one. This is predicted to be a splice site variant. It will weaken the native splice acceptor site and create a new one. And this is expected to cause aberrant splicing and result in an abnormal protein. So this is classified as pathogenic. This mutation wasn't seen that often, but most commonly in the lung, liver, esophagus, urinary tract, upper air digestive tract, which is, if you look, the top one is in the larynx, which is close to the hypopharynx. So not that that's definitive at all, but at least that was documented in the small amount of cases present in Cosmic. And that brings us to our third poll question, which is, what is the source of the neck mass? All right, so in all of these cases, I guess we all agree that these molecular tests, in combination with the clinical picture, morphology, immunohistochemistry, pointed that they were, from the same origin. And it's important to note that all cases can have a lot of different conflicting parameters. In some cases, it could be the clinical picture. In some cases, it could be the morphology. In some cases, it could be the immunohistochemistry or molecular results. Molecular testing can help add evidence in these cases and push us one way or the other, as it's something slightly more objective. Hotspot mutations are definitely less reliable for an exercise like this. But this is really about arriving at the most accurate diagnosis and conclusion for the patient and getting down to really what is the truth of what's happening to this patient, what's happening in this tumor or in this MET. And I think we're best served by integrating all the evidence, clinical, histomorphology, immunohistochemistry, as well as molecular testing. So that's all I have for today. I'd like to open it up now for questions, discussion. What do you guys think about these cases? Have you seen anything similar in practice?